Good evening, everyone. I'm Dr. Akansha from India. I'm a third year pathology PGJR. Today, I'm going to present a poster. Title of my poster is Non-Invasive Follicular Thyroid Neoplasm with Papillary-Like Nuclear Features, a new entity. Introduction. The Endocrine Pathology Society Conference for Re-Examination of Encapsulated Follicular Variant of Papillary Thyroid Carcinomas was convened on March 2021. 2015 in Boston had issued the term non-invasive follicular thyroid neoplasm with papillary-like nuclear features. Most common papillary thyroid carcinoma subtype is follicular variant, representing 30% of all PTCs. Most common in middle-aged women, 4th to 5th decade in women presenting with single dominant nodule. Follicular architecture is dominant finding with nuclear features of PTCs. Nuclear features include enlarged, elongated, and overlapping nuclei membrane, irregularities, chromatic clearing, and a glassy nuclei. The diagnostic criteria include encapsulation or clear demarcation from adjacent thyroid tissue, follicular growth pattern is less than 1% papillae, no Shamoma bodies, less than 30% solid trabecular insular growth pattern, nuclear alteration of papillary carcinoma with a score of 2 to 3, tumor interface with surrounding tissue, no necrosis, and no high mitotic activities. That is less than 3% mitosis per 10 high power field. A case report. A 25-year-old female presented with complaints of midline neck swelling, moving with deglutination since 2 years, along with history of weight loss. Thyroid profile was total T3 was 1.52, total T4 was 11.57, and TSH was 1.19. On USG, thyroid suggestive of bilateral enlarged thyroid with multiple colloid adenomatous nodule. On FNSE was done from midline neck swelling. Cytological diagnosis rendered was colloid goiter. The smear showed scattered and few clusters of follicular epithelial cells, along with many cyst macrophages and hemosiderophages in a blood mixed colloid background. So this is the figure. Figure A and B, figure 1-2 shows scattered and few clusters of follicular epithelial cells along with many cyst macrophages and hemosiderophages. On histopathology, we received right and left lobes of thyroid. Right lobe was globular gray brown, measuring 3 into 2.5 into 1.5 centimeter. Left lobe was globular gray brown, measuring 6.2 into 5 into 2.5 centimeter. Left lobe cut section showed well encapsulated nodule with cystic areas filled with colloid and hemorrhage, with gray-white areas and few areas of residual thyroid. On cut section, right lobe shows capsulated homogeneous gray-white surface and colloid-filled cystic areas. So this is the gross picture. On microscopy, multiple section studies from bilateral lobes of thyroid reveals well-demarcated capsulated tumor composed of colloid-free predominantly microfollicles, occasional abortive papillae that is less than 1%, and occasional trabeculae lined by overcrowded tumor cells with oval optically clear nuclei with significant nuclear clearing and grooving with scanty cytoplasm. Surrounding thyroid shows colloid-filled thyroid follicles with goitrous changes. No capsular or vascular invasion is noted, no Shamoma bodies, and no tumor necrosis is seen. Mitosis is less than 3 per 10 high power field in section studied. Our features were suggestive of non-invasive follicular thyroid neoplasm with papillary-like nuclear features. NIFTP. Figure 3. This is the figure 3. This figure shows tumor composed predominantly of microfollicles. Figure 4 and 5 shows overcrowding and nuclear clearing. This is the figure 6 showing tumor cells arranged in follicular, trabecular, and papillary pattern with individual cells showing optically clear nuclei with grooving and occasional prominent nuclei. Now discussion. The non-invasive follicular thyroid neoplasm with papillary-like nuclear features has the following criteria. Inclusion criteria is encapsulated, well-demarcated, a follicular architecture with less than 1% papilla, the nuclear features of papillary carcinoma with a score of 2 and 3. Exclusion criteria are any invasion, Shamoma bodies, tumor necrosis, more than 3 mitosis per 10 high power field, more than 30% solid trabecular insular growth, characteristics of other papillary thyroid carcinomas variant such as tall cell or columnar cell. Differential diagnosis of NIFTP. So differential diagnosis include follicular adenoma with papillary hyperplasias, encapsulated follicular variant of PTC, non-invasive encapsulated classic PTC, follicular tumor of unknown malignant potential, well-differentiated tumor of uncertain malignant potential, encapsulated follicular variant of PTC. So follicular adenoma and follicular carcinomas. Follicular adenoma is defined as a benign encapsulated tumor that shows evidence of follicular cell differentiation and lacks evidence of capsular, vascular, or any other type of invasion, and the nuclear features of papillary family of neoplasm. The lack of immunoreactivity of galectin-3, HbME1, and CITED1, and the retention of CD56 helps to distinguish adenoma from NIFTP and follicular variant papillary carcinoma. Follicular adenomas. The first picture shows intact fibrous capsule around a follicular adenomas, and second showing microfollicular pattern of growth in follicular adenoma. Now, well-differentiated tumor of unknown malignant potential. The term well-differentiated tumor of uncertain malignant potential has been proposed for cases with questionable PTCs type nuclear changes and no or questionable invasion. This is also the term used in 2014 Armed Force Institute of Pathology Cycles on tumors of thyroid and parathyroid glands. In 2017, WHO classification, the term well-differentiated tumor of uncertain malignant potential is reserved in this classification for tumor with well-developed to incompletely developed PTCs type nuclei and questionable invasion. So encapsulated tumors are follicular tumor of uncertain malignant potential is an encapsulated or well-circumscribed tumor composed of well-differentiated or follicular cells with no nuclear features of papillary thyroid carcinomas and with questionable capsular or vascular invasion. This is a tumor intermediate between follicular adenoma and follicular carcinomas. Now, well-differentiated tumor of uncertain malignant potential is an encapsulated or well-circumscribed tumor composed of well-differentiated follicular cells with well-developed or papillary developed PTCs type nuclear changes and with questionable capsular or vascular invasion. The DTUMP is which capsular vascular invasion has been included by all means and are called non-invasive follicular thyroid neoplasm with papillary-like nuclear features. Recent changes in the WHO classification. New entities are follicular tumor of uncertain malignant potential, well-differentiated tumor of uncertain malignant potential, non-invasive follicular thyroid neoplasm with papillary-like nuclear features, encapsulated variant of PTCs, encapsulated angio-invasive FTC, hurdle cell adenoma, hurdle cell carcinomas. New designation of ICD code, follicular variant of PTC, papillary microcarcinomas, columnar cell variant of PTCs, oncocytic variant of PTC, minimally invasive FTC, polarly differentiated thyroid carcinomas. So the fourth edition modified the definition of PTC and stated that PTC is a malignant epithelial tumor showing evidence of follicular cell differentiation and a set of distinct nuclear features. PTC is usually invasive. Papillary invasion or cytological features of PTCs are required. These changes were also intended to reduce overdiagnosis and overtreatment of low-risk PTCs. The majority of encapsulated PTCs without clear-cut invasion were downgraded to the borderline tumor category, including well-differentiated tumor of uncertain malignant potential and non-invasive follicular thyroid neoplasm with papillary-like nuclear features. PTCs were still heterogeneous tumor genetically, and the nuclear features alone was not successfully correlated with genetic alteration of red PTC gene arrangement, BRAF, V600E mutation, and RAS mutation, an accurate identification of the true biological nature of the tumor. The two types of nuclear features between Asian and Western thyroid practice, they were called either PTC type nuclear features that have fully developed PTC type nuclear changes often observed in BRAF, V600E mutated, PTC-like nuclear feature, delegated nuclear changes using the nuclear score guide that were often seen in RAS mutated PTCs and NIFTP. Immunochemistry. When all three markers, HbMA1, galectin-3, and CK19 are positive in a follicular pattern tumor, a diagnosis of EFB, PTC, or NIFT may be confirmed. That is encapsulated follicular variant of papillary thyroid carcinomas. Genetic profile of NIFTP. NIFTP share molecular alteration with other follicular pattern thyroid tumor and have high prevalence of RAS family mutation and sometimes PRAC and TATA gene fusion. BRAF K661E mutation can also be present. BRAF V600E mutation and RED fusion characteristics of conventional PTCs are absent. Prognosis on predictive factors. Provided a tumor is completely removed and careful examination of tumor capsule interface reveals no capsular or lymphovascular invasion, the risk of reoccurrence of other adverse events is extremely low, that is less than 1% within the first 15 years after resection. Incomplete excision with positive resection margin may lead to tumor reoccurrence. NIFTP can be treated with lobectomy, allowing patient to avoid complete thyroidectomy and radioactive iodine therapy. Conclusion. To obligate cancer over diagnosis and over treatment, a working group of the Endocrine Pathology Society had critically re-examined the encapsulated follicular variant of papillary carcinomas, and Nikiforov et al. Has introduced the diagnostic term NIFTP for this lesion. So this is my poster. I have already discussed the introduction, case report, result, gross and conclusion. So this was my poster presentation. This is my bibliography. All the references I have taken from 2 different articles and books. Thank you.